Welcome to Peds Doc Talk TV. I am Dr. Mona Amin, a board-certified pediatrician and mom, and it has been 4 months since I released a new episode here on Peds Doc Talk TV, and it feels so good to be back. I am talking all about bronchiolitis, RSV, what it is, what are the symptoms, and what to do about it. This video is brought to you by the New Mom Survival Guide, an online digital e-course created by me to educate, empower, and create community for mothers as they embark on their journey. For more information, click the link in the caption. Before we continue, make sure you hit that subscribe button because that's how you stay up to date on all of the videos I will be releasing here on Peds Doc Talk TV. And here we go. Bronchiolitis is an infection that causes the small tubes of the lungs, the bronchioles, to get inflamed or swollen. This makes it harder for babies to breathe. It is more common in infants or younger children under 2 because of their smaller airways. Bronchiolitis is different than bronchitis. Bronchitis is something that we see in adults, but children, especially children under 2, rarely or never get bronchitis. Bronchiolitis commonly gets referred to as RSV. RSV is the respiratory syncytial virus. It is one of the viruses that can cause bronchiolitis. But in actuality, bronchiolitis is a medical condition that can be caused by multiple viruses. Things like the flu, things like rhinovirus, things like enterovirus can all cause bronchiolitis. It's just that RSV is one of the most common viruses that do cause this condition. RSV is notorious for causing bronchiolitis because RSV causes a lot of congestion. That congestion causes a lot of mucus, which causes a lot of inflammation that can affect the bronchioles, leading to bronchiolitis. RSV in adults can seem like a very bad cold with a lot of congestion and maybe a cough. But in children, especially infants and toddlers under 2, it can cause difficulty breathing and wheezing in some instances. The younger the child, the more concerned we are going to be with RSV and bronchiolitis. This has to do with their anatomy and the size of their airways. If an adult gets RSV, they're likely going to be okay because their airway, including the bronchioles, are much larger. But a baby and a toddler can have a harder time clearing that mucus and subsequently can lead to the complications of bronchiolitis. A typical RSV season runs from late fall to winter, with a peak usually in February. Interestingly enough, states like Florida see their peak much earlier, so their RSV season ends by November. But because of the COVID-19 pandemic, we are seeing shifts in the season of RSV. Notably, we were seeing a lot of cases in the summer all around the country when it is unseasonable for RSV to be so high. So I wanted to create this video so that you are aware of the symptoms, when you need to seek medical attention, and what you can do at home to manage the symptoms. Bronchiolitis has a pretty classic presentation. It can start like a common cold that looks like a runny nose or stuffy nose with or without fever. By day 2 or 3, the child is going to have shortness of breath, difficulty breathing, and their cough may seem to be getting worse. Think of it as a cold that has gone deeper into the chest. It's not a bacterial process that likely needs antibiotics, but it's a virus that has caused so much congestion and subsequently inflammation that it's impacting the bronchioles or the small tubes of the lungs. Now remember, signs of distress in your child may not always be RSV bronchiolitis, but I wanted to go over what a child with bronchiolitis can look like on day 2 or 3. When you look at this video, you can see the child's chest moving in and out. This is not a normal breathing pattern. You can see that they're sort of labored in their breathing, tugging in and out. You may also see nasal flaring, where the nostrils are flaring in and out. This is much different than their normal breathing pattern. Watch your child's rib cage, and if you're noticing the tugging that goes in and out, if you watch here at the top of their sternum and you see tugging in and out or nasal flaring, you would want to get your child evaluated to make sure a clinician can listen to their chest and see if they need any additional therapy. Other signs can be grunting with this difficulty breathing, high-pitched whistling sounds that almost sound like a wheeze when they breathe out. Difficulty drinking. Remember that if they're having difficulty breathing, they may have a hard time drinking because in order to drink comfortably, you have to be breathing comfortably. When I listen to the chest of a child with bronchiolitis, it sounds like a washing machine. I listen with my stethoscope and I can just hear mucus swirling around. It's something that we hear commonly that is also called rhonchi. You may also hear wheezing if you were to listen with the stethoscope. Your child may also have grunting sounds, but remember, grunting sounds alone are not always a cause for concern. But if it's grunting with difficulty breathing, those ribs tugging in and out, the sternum right here tugging in and out, the nostrils flaring in and out, you're gonna wanna get your child evaluated. Remember, we as adults can get RSV. We can get many of the viruses that can cause bronchiolitis. But the difference is in children, these viruses can cause more difficulty breathing because of the smaller airways. Symptoms can appear anywhere from 2 to 8 days after initial exposure. The duration of symptoms can vary child by child. I want you to watch out for that day 2 to 3, where we do see that difficulty breathing start to peak. If you're noticing that difficulty breathing on day 2 or 3, or even to day 4 of illness, you definitely want to seek medical attention. RSV is spread by person-to-person contact or touching shared surfaces, similar to any respiratory virus that we see in our community. You can return to school or daycare once your child is fever-free without any medicine. That includes Tylenol or Motrin. They are not needing any therapies such as albuterol, such as saline, which we'll go over, and they're back to their normal spirits. This means eating, drinking, pretty much close to baseline. How I describe it is that if your child is comfortable enough for you to be taking care of them, then they can go be taken care of by someone else. But they also have to be fever-free for 24 hours without any medicines to mask a fever. Typically, RSV is diagnosed by clinical presentation. That child who has congestion, maybe a cough, maybe a fever, and day 2 to 3 is now presenting with difficulty breathing. At some hospitals or urgent cares, they will be able to swab your child. They'll stick a little swab into their nose to say that, hey, this is actually RSV. This is not necessary to make the diagnosis. As a FYI, a lot of this is done in hospitals for cohorting. For example, if your child is sick and needs to be admitted, they will swab the child, not because it's really going to change management, but because we need to know in a hospital setting that this child has RSV, so that when they are placed in certain rooms or certain parts of the hospital, that they can say that this child has RSV, this child has RSV, so that the staff is aware of what viruses are existing in which rooms. But if your child's pediatrician in the outpatient office is not swabbing them for RSV, I don't want you to feel like they're not doing a full thorough workup. The clinical picture can tell us a lot about what's happening, and we often do not need that swab to tell us that clinically this looks like bronchiolitis. Could it be one of the other viruses that cause bronchiolitis besides RSV? Sure, but the management would stay the same if the child has any difficulty breathing, if the child has any therapies that are needed. So having the diagnosis really doesn't change our management because we're going to be taking care of it the same way. If your child is sent home with bronchiolitis, you're going to monitor their breathing difficulty, their hydration, you're going to monitor for persistent fever. If anything changes or you are concerned, seek medical attention. Please watch my videos on cough and cold symptoms and Fever 101 for more information on how you can help with symptoms. Things like saline in the nose, things like baby Vicks rub for children under 2, things like a humidifier can really help in terms of those congestion symptoms. But with bronchiolitis, we want to keep a close eye on their breathing and their hydration to make sure we don't need to add anything else for them. But if your child is dehydrated, which means that they're making less tears, they're not making as much wet diapers, they seem fragile or listless, you're going to want to seek medical attention for that dehydration. The other big thing is difficulty breathing, which I mentioned was those retractions that you see in the rib cage, retractions that you see here, and nasal flaring that you may see in the nose. The other reason we want to see the child is fever persistence, or just overall inconsolability despite meds. So even if your child is acting okay in terms of how they're breathing and their hydration is okay, if they are seeming very inconsolable with that fever, Motrin or Tylenol, depending on their age, is not helping, we want to see your child to make sure they don't have an ear infection, to make sure that we listen to their chest, to make sure no other intervention is needed for the well-being of your child. If your child is dehydrated, you may need to go to the emergency room. There, they may give your child IV fluids. IV fluids is when they set up an IV and give fluids through that line to hydrate your child. In some cases, they need that to perk them up so that they can breathe more comfortably. In other situations, if your child is having severe difficulty breathing, looking dehydrated, your child may be admitted for observation to make sure that their breathing status improves and to make sure that their hydration status improves. If your child is having difficulty breathing, you can go to the ER or your child's clinician's office. However, if your child is very listless and having very low energy, your best bet would be to go to the emergency room because they will evaluate if your child needs IV fluids and if they need any support for oxygen or any support for their breathing. Your child's clinician's office, if they're open, can guide you. There may be chances that you go to the office, they look at you, and then they have to send you to the ER. This is obviously for the best interest of your child. So you can always call your nursing line and see what the best step is based on your child's symptoms, if you need to go to the office or if you need to go to the ER. But how I say it is, if you're looking at your child and they seem very labored in their breathing, they're not drinking anything, they're just very uncomfortable, it may be beneficial to go to the ER to see what the evaluation is, and you may be admitted or you may just be able to go home with certain medicines or interventions. If your child is mildly labored, meaning that they're comfortable but you see some tugging in their chest, they're hydrated, their oxygen saturations are normal, their fever is there but it's controllable with medicines, and their comfort is there, your child's clinician may just recommend nasal suctioning, which helps alleviate that mucus from the nose. They may recommend a humidifier. These are things that we would do for any child with a cough and cold, with close observation of their breathing difficulty and their level of hydration. In more moderate to severe cases of difficulty breathing, the management will depend on the child's work of breathing, how fast they're breathing, and also their oxygen status. In a child who's not really working hard to breathe but has a lower oxygen, they may just recommend oxygen via something called a nasal cannula. This is something that goes into the nose and helps deliver oxygen to support their lungs. In cases where the child is having a lot of difficulty breathing, there may be other interventions. These are things in the hospital like something called a CPAP machine, and in very severe cases, it may be something called intubation. Intubation is where a breathing tube is placed to support the child while they recover. Remember, bronchiolitis is usually caused by a viral process. RSV is a virus, so there's no antibiotic that is needed, but we need to support the child so that their body can heal itself. So things like intubation, things like oxygen, these are things to support the child so that their body can heal from this virus and that you all can go home. In some cases, some doctors still do prescribe steroids. It is not usually recommended to prescribe steroids in bronchiolitis. The guidelines have now changed that really it's supportive care, it's hydration, IV fluids, it's oxygen support and breathing support if needed. Some doctors still do prescribe steroids, and this may just be a case-by-case basis based on the symptoms. Some clinicians still do prescribe albuterol. Albuterol is typically used for asthmatics, and RSV is different than asthma. But sometimes we do see that the albuterol treatments can help. So it's really up to your child's clinician to discuss with you what are the options based on your child's symptoms and what's going on in the office. Another possibility is something called nebulized saline. Saline can be administered through a nebulizer machine and can in many ways help break up that mucus. This is also another treatment that your child's clinician may recommend. Overall, the supportive care is what we need. We need to make sure that your child is staying hydrated. We need to make sure that their breathing is comfortable. So many times in bronchiolitis, if your child is being sent home from the clinician's office, they may recommend coming every day or every other day to follow up your child's clinical status. If you go to the hospital and your child needs admission, rest assured the reason for this admission is to monitor all the things I mentioned. How's your child breathing? Do they need any other support? Do they need anything for IV fluids or hydration? Sometimes being in the hospital can be the best thing for your child so that they can recover. I know as a mom that it can be very scary when your child is admitted to a hospital, but sometimes it can be the best place for their body to heal. Over 50,000 children get admitted to the hospital with bronchiolitis every year. Last year, 2020, was a little lower because of the pandemic and the precautions that we had. But know that it is common and outcomes are good in terms of what we're monitoring and what we have to do, but sometimes your child has to be in the best place possible, and that may be the hospital. The best prevention for RSV and bronchiolitis and all of the other viruses that can cause this are the same things we would do for any respiratory virus. Things like hand washing, things like covering our nose and our mouth when we sneeze and washing our hands, things like limiting visitors, especially to our newborns and our premature babies. If you must have visitors, you can have them wear a mask or assure that no one is under the weather. I know everyone wants to see newborn babies, but if they're not feeling well, if they're under the weather, they should hold off on that visitation. If that visitation needs to happen because it's you or your partner or someone who's taking care of your baby, mask them. Remember, masks help prevent against the spread of respiratory illnesses, including RSV. For older siblings that may be in childcare, they can still go to childcare. You can weigh the benefit and risk with that situation with your child's clinician. But if they do go, a habit that you can get into is having them kiss baby's feet. Focus on showing affection to the feet versus getting into the face. This can help protect the baby's mucous membranes from getting infected with RSV or other viruses that may be circulating right now. Another tip is to avoid utensils if sick. I know this can be really hard when we are with our children, but this is a simple way that we can avoid germ spreading in our home. Currently, there are no vaccines against RSV, but science is awesome and there are currently trials to create a RSV vaccine for children. Although there is not a vaccine, for some high-risk infants, there is something called Synagis, which is humanized monoclonal antibody that can help reduce a high-risk infant's risk of getting RSV and getting complications from RSV. This therapy is recommended in up to 5 months during RSV season for high-risk infants. Eligible children include premature infants, especially those born at less than 29 weeks gestation, infants with chronic lung disease of prematurity, infants with certain types of hemodynamically significant congenital heart disease, infants and young children with certain immunodeficiency states, and infants with pulmonary abnormalities or neurological and neuromuscular conditions that impair their ability to clear secretions from their upper airway. Remember, RSV is one of the many viruses that cause bronchiolitis, but we do end up calling it the same thing. Remember that other viruses can cause bronchiolitis, and always remember what to look out for. That difficulty breathing, the dehydration, all of the things that we would want you to look out for every virus. The best way that we can prevent the spread of RSV is hand hygiene, the same things that we're doing in this pandemic, but really remembering to always protect our youngest children. Bronchiolitis affects children usually under 2 years of age, more so because their size of their airways. So when we are taking precautions, we want to do the best we can to reduce the risk with the understanding that we do the best that we can. Thank you for joining me today. If you found this video helpful, make sure you comment below, share it on social media, and ask any questions if you have them, and I'll see you next week.